If you've ever woken up feeling like you basically slept face down in a field, or maybe you go through decongestant spray like it's going out of style,
Mhm.
then you know exactly why we're diving into chronic nasal symptoms today. That runny nose, the congestion that just won't quit, the itching, they sound maybe like small things, right?
Yeah.
But our sources show the impact is actually huge, often really underestimated.
Oh, it's absolutely true. We're talking about rhinitis here that covers both allergic and non-allergic types. And the effect these chronic symptoms have on your quality of life, your sleep, even just concentrating at work or school, it's really comparable to the burden someone with moderate asthma faces. It's a major health issue, often flying under the radar.
And here's something that really shocked me, setting the stage for our deep dive today. Medical surveys suggest the actual prevalence of allergic rhinitis is just staggeringly high, maybe up to 300 out of every 1,000 people. But then you look at general practice records. The reported incidence is way lower, like 49 per 1,000 patients a year.
Yeah, that huge gap tells us something really clear, doesn't it? Most people are just dealing with it themselves, self-treating, maybe suffering in silence. So our mission today is to cut through some of that confusion. We're using comprehensive medical guidelines to help you understand the differences between these kinds of rhinitis, how doctors figure them out, and, really importantly, the most effective, evidence-based ways to manage them. We want to give you the knowledge to hopefully finally breathe a bit easier.
Okay, let's start with what we're calling the patient paradox, because the data here is pretty fascinating. If so many people have this, but so few are seeing a doctor, what are they actually doing?
Well, it seems patients feel pretty confident. Our sources say up to 60% feel they can diagnose their own allergic rhinitis just fine. And a huge number, like 85%, use over-the-counter medicines before they even consider talking to a health professional.
Which I guess makes sense with easy access to information now. But what's the downside of all this confident self-treatment, especially thinking about compliance later on?
The downside is, well, compliance can be pretty disastrous when they do get professional treatment. We see between 40% and even 80% of patients stopping prescribed medication within the first 6 weeks. They often say it wasn't working fast enough or they didn't like the side effects. And here's a really key point. Patient satisfaction is inversely correlated with how bad the symptoms are. Basically, the worse you feel, the more likely you are to get frustrated and just quit the treatment.
Wow. So the people who probably need that consistent preventative help the most are the very ones most likely to give up on it, maybe looking for that quick fix from a spray instead. But beyond just feeling better day to day, we really need to talk about the connection between the nose and the lungs. That asthma link is critical, right?
It really is. Think of the airway as one continuous system. Allergic rhinitis is actually a recognized risk factor for developing asthma later on. If you have allergic rhinitis, there's roughly a 40% chance you also have asthma.
And flipping that around, if you already have allergic asthma, the link is almost certain.
That's right. For patients with allergic asthma, somewhere between 80% and 90% also have allergic rhinitis. There's this idea, the unified airway hypothesis, that suggests inflammation up in your nose can directly influence how reactive your lungs are.
Now, I've heard that treating rhinitis can mean fewer emergency visits for asthma attacks, but there's an important nuance here from our sources, isn't there, about whether treating the nose significantly improves actual asthma symptoms or lung function in trials.
Exactly. While treating the nose is generally associated with fewer ER visits for asthma, actual medical trials comparing rhinitis treatment against a placebo show the effect on overall asthma symptoms and lung function might not be, clinically relevant.
Okay, so that's a key insight. Treat the nose aggressively for quality of life, maybe reduce some inflammation overall, but don't count on it as your main strategy for controlling serious asthma symptoms. Robust asthma management is still paramount.
Precisely. You need both, but they target different primary outcomes.
All right, so we know we need to treat the nose, but treating it right means knowing what's causing the problem in the first place. Let's shift from symptoms to causes. How do we even start to separate true allergies from, well, everything else?
The number one tool, honestly, is listening to the patient's story, what doctors call the anamnesis. It sounds fancy, but it just means getting a detailed history. When and where your symptoms happen is often more telling than a lot of lab tests for distinguishing allergic versus non-allergic causes.
Okay, let's unpack allergic rhinitis first. That's the IgE-mediated one. What does that actually feel like?
It feels pretty immediate. It's that hypersensitivity reaction. Allergens land, trigger histamine release almost instantly. That irritates nerve endings really fast, leading to that classic quick early phase reaction. Sudden runny nose, intense itching, often explosive sneezing. You walk into a dusty room or a park in spring and bam, instant itch and sneeze. That's probably IgE at work.
And the patient's story gives us the timing clues. What are the typical seasonal patterns we look for?
Yeah, for seasonal sufferers, it's often predictable. Tree pollen, especially birch, that's often February through May. Grass pollen tends to hit hard from May to August. Then you have the year-round triggers. House dust mites often peak in autumn and winter when we're all indoors more. And pet dander, molds, fungi, those can be issues any time of year, especially in warm, damp places.
I often hear people say things like, my allergies suddenly got way worse, or I started reacting to stuff that never bothered me before. Is that this priming effect I've read about?
This is exactly the mechanism, yes. Priming basically means repeated exposure lowers your trigger threshold. Think of it like your allergy cup is already nearly full because of ongoing low-level exposure or previous reactions. Then it takes just a little bit more of that allergen, or sometimes even a different, usually harmless irritant, to make the cup overflow and trigger significant symptoms.
And that connects to oral allergy syndrome, or OAS, right? Like when eating an apple makes your mouth feel itchy if you have a birch pollen allergy.
Precisely. That's cross-reactivity. Birch pollen allergy is famously linked to reactions with apples, some nuts. Grass pollen allergy can cross-react with foods like carrots or celery. It shows how connected the airway and digestive system can be through these sensitivities.
Okay, so if the patient history, maybe some testing, rules out that IgE-mediated allergy, what's left?
Then we're looking at non-allergic rhinitis.
Yeah.
This is still inflammation, but without that specific allergen hypersensitivity driving it. The cause is often, well, unknown. We call it idiopathic. That's why it used to be termed vasomotor rhinitis. Kind of a catch-all.
But there are known triggers for this non-allergic type, even if it's not IgE.
Oh, absolutely. Several distinct categories. First, there's medication-induced rhinitis. The most notorious culprit is overusing those decongestant nasal sprays. We'll definitely circle back to that one. But other drugs like NSAIDs, ACE inhibitors for blood pressure, even some beta blockers can trigger it. Then you have hormonal changes like pregnancy rhinitis. And finally, rhinitis caused by irritants, tobacco smoke, sudden cold air or temperature shifts, alcohol for some people, even physical exertion, dust or fumes from paint or baking. Again, the anamnesis is crucial because treating rhinitis from paint fumes is obviously very different than treating a pollen allergy.
Right, makes sense. So let's move to prevention and non-medication strategies. Before reaching for prescriptions, what can people actually do to avoid triggers?
For seasonal pollen, the advice is fairly straightforward, but requires discipline. Keep your house and car windows shut during peak season and high pollen counts. Wearing glasses or sunglasses outdoors can physically block some pollen from your eyes. Definitely avoid activities like mowing the lawn if you react to grass. And a big one people forget, dry your laundry indoors. Pollen sticks to fabric like crazy when it's hung outside.
Okay, that makes sense for seasonal. What about the constant battle with house dust mites? That seems trickier.
It is. Dust mite control needs consistent effort. You really need to wash bedding frequently, at least every 2 weeks in hot water, 60 degrees Celsius, for at least an hour. That kills the mites. Having smooth flooring in the bedroom, like wood or vinyl instead of carpet, makes cleaning easier. And regular vacuuming and damp dusting of surfaces helps. Ideally, the person with the allergy isn't the one doing the cleaning, or at least wears a mask.
Now, here's where we hit something that I think will genuinely surprise a lot of listeners, especially anyone who's shelled out for special bedding. What's the latest guideline update on allergen-proof mattress and pillow covers?
This is a really significant change in clinical advice, yeah. The guideline now explicitly states that allergen-proof mattress covers are no longer recommended. The reason? A lack of solid evidence showing they actually make a difference in reducing symptoms.
Hold on, so that expensive strategy, the one recommended for years, is now considered basically ineffective based on the evidence. That's huge. That changes where people should focus their efforts and maybe their money.
It really does. Focus that energy and budget on the consistent hot water washing and cleaning instead.
Okay. Speaking of potentially difficult interventions, let's touch on pet allergies. The sources say removing the pet is the most effective step. That sounds really hard for people. Are things like air purifiers or keeping the pet out of just the bedroom seen as, well, not really cutting it compared to full removal?
The source material is pretty direct on this. Pet removal is often more effective than even optimal medication for severe pet allergies. Keeping the animal out of the bedroom certainly helps reduce exposure during sleep.
Yeah.
But yes, the most effective strategy is complete removal from the home environment. And if someone does decide to rehome a pet, they need to understand it's not a quick fix for the environment. Just putting the pet elsewhere for a week or two on a trial basis is pretty much useless. It can take months for those residual allergens to clear out of carpets, upholstery, and the air.
Good point about the time lag. Okay, one last non-medication thing. Saline nasal washes or sprays. Are they a useful treatment?
Nasal rinsing with physiological saline, yeah, can be a helpful addition. Studies show it can help reduce symptoms a bit when you use it alongside your regular medication. But using it as the only treatment, what we call monotherapy, isn't generally recommended based on the evidence. Think of it as a supportive measure, not the main line of defense.
Got it. Okay, let's move on to the medication roadmap itself. The guidelines use this stratified approach, right? Meaning the choice depends on how often symptoms occur, intermittent versus persistent, and how bad they are, mild versus moderate to severe.
Exactly. And moderate to severe generally means the symptoms mess with your daily life, affect your sleep, or stop you from doing normal activities.
So where do we start? Quick relief options first. Antihistamines.
Yep, antihistamines or AH. They're the sprinters, they work fast, usually kicking in within a few hours. They're the go-to for occasional or mild symptoms or when you just need relief right now. So great for as-needed use. You can get them as pills, common ones are cetirizine, loratadine, or as nasal sprays like azelastine or levocabestine.
Okay, fast relief. But for those persistent, maybe more severe problems, we need something that tackles the underlying inflammation more directly. That brings us to corticosteroid nasal sprays, right?
Right. Corticosteroid nasal sprays, or CSNS, are the marathon runners. They are the real workhorses for persistent rhinitis. They're considered significantly more effective than antihistamines, especially for chronic, long-term use, for prevention, and for really tackling that awful nasal congestion. The trade-off, though, is they're slower. They take several days of consistent use to reach their full effect. So you have to use them regularly, ideally preventatively, not just when you feel bad.
And there's a really important tip about how to use them to avoid a rare but nasty side effect like getting a hole in the nasal septum.
Yes, absolutely crucial. To minimize local irritation, nosebleeds, and that very rare risk of septum perforation. You need to spray away from the middle part of your nose, the septum. A simple way to remember is use your left hand to spray into your right nostril and your right hand to spray into your left. That naturally angles the nostril outwards, away from the septum.
What about patients with really severe persistent symptoms? Sometimes they ask for oral steroids, like a prednisone burst or even a steroid injection. Is that ever a good idea for just rhinitis?
Wow, yeah, that's a really important point and a major warning from the guidelines. Oral or intramuscular corticosteroids are strongly discouraged for routine rhinitis treatment. This is a key insight. Patients chasing that quick, dramatic fix with systemic steroids are taking on serious long-term risks. We're talking increased risk of osteoporosis, diabetes, Cushing's syndrome, all for essentially no proven benefit over using a nasal steroid spray correctly and consistently. The local treatment works very well and is much, much safer.
That's a powerful message, safer and effective locally. Okay, so if someone does have severe symptoms and needs both fast action and long-term control, can therapies be combined?
Yes, definitely. We now have combination nasal sprays available. For instance, sprays that contain both an antihistamine like azelastine and a corticosteroid like fluticasone in one device. Studies show these combo sprays are actually more effective than using either type of drug alone. Plus, the convenience of just one spray might help people stick with the treatment better, improve compliance.
Makes sense. And quickly, what about pregnancy and breastfeeding? What are the recommendations there?
The general rule is always to prefer local treatment because very little gets absorbed into the body. So, a fluticasone nasal spray is considered the first choice, safe and effective locally. If for some reason a short course of an oral antihistamine is absolutely needed, loratadine is generally the preferred option, followed by cetirizine. But local first, always if possible.
Okay, we've covered the main roadmap. Now, let's dig into some of the trickier situations, the difficult cases. First up, that infamous spray addiction trap.
Yes, rhinitis medicamentosa. Rebound congestion. It's a classic problem. It happens from using those over-the-counter decongestant sprays like xylometazoline too often or for too long, usually more than 5 to 7 days. The nasal lining basically gets hooked on the drug. When it wears off, the blood vessels swell up even more than before. The rebound effect makes you feel even more congested, so you reach for the spray again, and you're caught in this really vicious cycle.
And the sources mentioned something alarming, that once you've had it, you're super susceptible to falling back into it, even after being off the spray for a long time.
That's the real danger, yeah. Someone could be clean for over a year, use the decongestant spray just for a couple of days for a cold, and boom, the rebound congestion can come right back. The only real fix is stopping the decongestant completely. Cold turkey. To help manage that initial miserable rebound swelling, sometimes doctors will prescribe a corticosteroid nasal spray temporarily. It helps calm that intense inflammation. It's technically off-label for the specific purpose, but it can help bridge the gap.
Okay, stopping is key. What about the group we mentioned earlier, people with true idiopathic rhinitis? No allergies, not medication-induced, just chronic inflammation for no clear reason. How is that treated?
For idiopathic rhinitis, the typical starting point is an azelastine nasal spray, the antihistamine one, usually tried for up to about 8 weeks. If that doesn't provide enough relief, then a corticosteroid nasal spray, CSNS, is the next step. Or there's another option, particularly useful if the main symptom is just a constant watery runny nose, what we call rhinorrhea. That's ipratropium bromide nasal spray.
Ipratropium bromide. Isn't that usually used for lung conditions like COPD? How does it help a runny nose?
It is used for COPD, yeah, but it works by blocking certain nerve signals that stimulate mucus production, so it directly targets that excessive watery discharge. It can be particularly helpful for that specific symptom, especially sometimes in older adults where a persistent runny nose is the main complaint.
Fascinating. Okay, moving up the ladder to the really tough advanced cases, the ones that just don't respond even to maximum medical therapy. What's next? Immunotherapy.
Exactly.
Yes.
Specifically, subcutaneous immunotherapy, or SEIT, often called allergy shots. This is reserved for severe confirmed allergic rhinitis that hasn't responded well to consistent use of maximal medication, including CSNS and antihistamines.
And that involves getting regular injections over several years.
Correct. It's a long-term commitment, usually 3 to 5 years of injections. It works by gradually desensitizing your immune system to the specific allergens you react to. It is effective. Studies show it significantly reduces symptoms and medication needs long-term. However, it's not without risks. There's a small but real chance of a severe systemic reaction, even anaphylaxis. It's estimated around 0.1 to 0.5 reactions per 1,000 injections. That's why it has to be started and monitored in a specialized medical setting, especially the initial build-up phase.
Right, definitely not something to undertake lightly. And finally, what about surgery? When does that come into play?
Surgery is really only considered when the primary problem is severe physical blockage in the nose, and medical treatments haven't helped that feeling of obstruction. This could be due to things like a severely deviated septum, the wall between your nostrils. Surgery to fix that is called septoplasty. Or it could be chronically swollen tissues inside the nose, called turbinates. Surgery can reduce their size, contrarreduction, or turbinoplasty. Septoplasty, for example, can be quite effective for improving airflow in the short term. But it's important patients know that symptoms of obstruction can sometimes come back over time, even after successful surgery.
Wow. Okay, so this deep dive really shows that tackling rhinitis isn't just about picking a drug off the shelf. It really requires, first, figuring out the cause. Is it allergic, idiopathic, medication-related? And second, carefully matching the treatment type and intensity to the pattern of symptoms. Fast antihistamines for quick relief versus those potent but slower corticosteroids for long-term control.
Absolutely.
Yeah.
But threading through all of this is the challenge of adherence. It keeps coming up. We know rhinitis hammers quality of life. We know it's strongly linked to asthma. And yet, we see these incredibly low compliance rates, 40% to 80% of people stopping prescribed meds within weeks. So it really makes you wonder, and maybe this is the final thought to leave listeners with, is the biggest hurdle to actually breathing easier pharmacological finding the right drug? Or is it more about human behavior, about adherence, about the willingness to stick with a long-term preventative routine instead of just chasing that instant, but often temporary and sometimes risky fix?
A really provocative question. Definitely something to think about. We'll leave it there for this deep dive.